Hey everyone, welcome back to the show. This is the Neuro Wellness Podcast. I'm your host, Dr. Joseph Kappas, and today I'm joined by my guests, not one, but two, Adam Wolf and Dr. Mike Drozwicki, for his second appearance. Welcome, guys.
Thank you.
Thank you for having me, Joe. Nice to see you, Mike.
Good to see you as well.
Yeah. So I'm pretty excited to talk to you two today. You have a book that you've released that you've Adam, you were the primary author, and then Dr. Drzewieki, you were the consulting doctor too as well, right?
Correct.
So
the neuro editor, as I like to say.
Neuro editor, yes. So what is the book about, and what is it? What's it called?
Well, first, thank you for having me. This is great, and I'm excited to be here. And when I got started on the book, and I think as Mike came into it, and I'm sure we'll share with how he did, I think it turned out to be way more of a project than either one of us thought it would be. So, Mike, thank you for putting up with me on it. But the book is called Foundations of Movement, a Brain-Based Musculoskeletal Approach. And it's really sort of, we all are movement practitioners. That's the way I kind of look at it. And I come to movement differently than you all come to movement. And the way that I look at it is sort of from a musculoskeletal movement paradigm, three-dimensional movement paradigm. So like maybe almost a bottom-up driver versus you all looking at movement from a brain-based perspective that is maybe sort of that top-down driver. And so when I had the opportunity to be exposed to these thought process, it just sort of made sense. And as I sort of started to try to put together what my hierarchy, the book initially was called My Fundamentals of Intervention. And it was written about like a hierarchical, when somebody comes in, what can I anchor to regardless of like who that person is or what their diagnosis or their injury work is. I tend to work more in an outpatient musculoskeletal type world compared to a lot of the dizzy or the brain-based type stuff you all do. And so it's sort of the book was written around that concept. And as I was writing it and recognized that my base of knowledge or depth of knowledge on the brain is still something that I'm learning, I feel like intensely, and I have the opportunity to be around some great people that know it. But when I started to go back and read about that neuro component of it, I just didn't feel, I felt like a poser, and I didn't feel like I would be able to lend the authenticity to it. And so sort of the story about how I'd go even deeper into it is that at that time, I said to myself, I'm just going to put the book down and learn as much as I can on this subject for a year. And that sort of coincided with me having a lot of anxiety and sort of not being in a great space in my life and some depression. And having known I'd become friends with Mike over the years through some mutual friends and courses. And we live in the same community. And so Mike started to treat me for my anxiety and depression. And it really made sort of a big difference in me. And then my ability to apply that information, because we always learn, right, it's selfish. Everything we learn is selfish. I mean, I feel like anything I do to somebody I've had done, and it's, I need to learn more about that. And so it made me want to learn more about it. And as Mike and I got talking, it just made sense for Mike to sort of write on that perspective rather than me try to add a voice that I felt really authentic, and I couldn't talk on it to the degree that or the expertise that I could on a lot of the other subjects in the book. I felt that Mike would be able to do that. And we share a lot of passions for movement. Over a number of beers, Mike and I have talked about that and sort of how he's helped me to sort of that top-down maybe approach of understanding the brain and how to approach it from my world, which is a musculoskeletal, not necessarily dizzy, not necessarily like clinical neuro issues, but how I can apply that information. And then vice versa. I think one of the things, and I think I asked Mike that, but maybe I'll ask Mike that, but Mike's, I think I've helped him to have that sort of bottom-up approach. And when he's working with maybe some of his higher level people and getting into performance, where he can apply some of like maybe more the movement-based thing that I'm maybe good at. I'm rambling here, so I'll shut up here for a second.
No, that was great. Oh, go ahead, Doug.
Yeah, I was just going to say, to piggyback off that, that's absolutely true, Adam. I mean, kind of my I was definitely very, very honored to be asked to write this. This is my first time kind of writing in a book in any sort. So absolutely, I appreciate that from you. I know I've told you that before, but with Adam and his, like, he talks about his movement or his idea of movement and how that works. And his, it's super impressive watching him break down how people move from a musculoskeletal standpoint, meaning like just looking at a gait pattern, looking how their knee moves, looking how somebody's jumping or running or moving their shoulder or reaching for something, and his ability to kind of see things in a different way than I would say most people see movement. He's looking, maybe seeing things in different planes, or, kind of the same way that how I look at a patient and see their, I see their eye movements, or I see how they're holding their position or posture or whatever. And it gives me I don't look at them as so much the person sitting right there, but I kind of see the different pathways, or I see the different things that are going on, and think of it a little different way. Adam does that exact same thing with movement, right? So like how the knee is moving, and how, when there's a little bit of a twist to this part, or how the midfoot is moving through the gait pattern, things like that. He sees these things that my eyes don't see, for sure. He's taught me some of those things, but kind of seeing things from a completely different expertise, right? Completely different level than a lot of people look at. And then it was super cool, as like he said, over maybe 1 or 2 beers from time to time, having just fun conversations about movement, and him asking me about what it means when the movement looks like this from a brain approach, and then me asking him, well, what is, I think of it this way, but when there's actual movement going on, what's your thought process? What are you looking at? How are you analyzing it? And then it kind of blossomed, of course, the friendship and everything there, but and then even into the more of the clinical stuff, and being able to bounce ideas off each other has been a super cool thing. And the way the book kind of turned out, it's almost like we kind of bounce the same bouncing of ideas that we have with each other in conversation. It's almost kind of like that in the book too, where it's like this kind of bouncing back and forth, which kind of turned out kind of cool, because it's just exactly how we talk on a regular basis. Yeah.
And a number of people have said that as well. They've said that, they can hear us that know both of us, but it's really what it is. As I would go through, the way we sort of was arranged is, as I would write something and Mike had a thought on it, we put it in highlights. And so then the highlight would be his voice of talking about what I had just talked about. So it worked out. And before we keep going, I just want to say that it's funny, Mike, I kind of giggled because you had talked about, you were impressed with the way that I saw things and we were talking. And I remember like bringing patients to you all early on in our relationship as I was starting to get to know you, and being just floored. I think, Joe, you were like just starting there, if I'm not mistaken too. But I would be floored by watching somebody walk and seeing what you picked up on versus what I was picking up on, and just being like, holy shit, I missed it. Like, what have I been doing for 10 years? That's really sort of what I thought about it as we were coming in. So it's fun to hear you sort of say the same thing here, and differently.
Yeah. And I think just from me reading it so far, I thought it's such a comprehensive look at, your lens, and then Mike's lens, and how you really married those two, and it really completes this complete picture. And I think it's absolute gold for any practitioner out there who's treating patients in either the physical therapy or the chiropractic or the neurological world. I think this book is phenomenal. Before we dive too deeply into the book itself anymore, I know we got Dr. Mike's story, season 2, episode 1. So if you want to hear that, you can go back and listen to that episode. But we got a little bit of background information on you, Adam, but can you kind of walk us through your career and kind of what led you to your love for movement and treating patients?
Yeah, sure. Thank you for that question. I've been a physical therapist for 15 years. I went back to school after being out of undergrad for 5 years. I was 26 when I went back. And I got into movement and business, I guess. Both my parents are entrepreneurs. My mother and grandparents owned a catering company when I was a kid, and my father owned a health club. And so I had sort of both those worlds. And as I came out of school, I wasn't really interested in sitting behind a desk and wearing, a suit and having to shave every day and dress shoes and all that. I still don't know how you all do it, dress shoes and button-down pants. But, people ask why I became a PT, and I did, only half joking when I say I wanted to wear gym shoes, sweatpants, and not shave every day, and then I get to kind of do one of these and smile at them. But I knew that I wanted to help people. I knew I wanted to be one-on-one and intimate with them. I didn't want to sit behind a desk. And PT just sort of made sense. And so right off the bat with PT, my father is in the fitness industry, and he was exposed to applied functional science and Gary Gray, who's a physical therapist, and sort of what one would call the father of function, sort of within the physical therapy world, and how to look at three-dimensional movement. So I was exposed to that quite early in my career. In fact, before I went to PT school, my father gave me 85 3-hour videos and said, here, watch these. And so I went in with a really firm base in terms of this. And then we fast forward through school, and I came out and I dove in really hard into three-dimensional movement, applied functional science, and got to know it. Around that time, I've been on my own. I've owned my own business since 2009. Sort of probably too early in retrospect. I started my own business, but been on my own in various. Typically, for a lot of years, I was in personal training studios. And I found that to be a really good marriage. I really feel that like trainers in the fitness community is actually the gatekeepers to being able to help people way more than like the doctors. And so I had some practices within personal training studios, and then just got to the point of wanting it to be a certain way. I mean, what I say is like the philosophy of movement. I just needed everything to align in terms of the personal training and the massage and physical, everything that, you know, one would do within a clinic or working with somebody from a movement perspective. So almost a year and a half ago, I opened up the Movement Guild, which is where we're at right now, in what has become sort of a film studio. We do podcasts and have a lot of online courses, and I film content. So this is the yoga studio, but we've turned it into a nice little recording center here. But we opened up the Movement Guild, which is in downtown Chicago, 5 blocks from where the Bulls and Hawks used to play before we were all locked down. And so the Movement Guild is physical therapy, massage therapy, personal training, yoga recovery, mobility type classes. So we have those type of things. My dive into the brain, and I guess neuro world, comes from a mutual friend and colleague of all of ours, Dr. Nick Studholm, who I met through the Gray Institute, and I did their 40-week fellowship program in applied functional science, and so did Nick. And so we struck up a friendship, and through that, he sort of got me into a lot of the brain-based stuff. He introduced me to FNOR, Functional Neuro-Orthopedic Rehab, which is sort of I think it all kind of comes through the Carrick Institute at this point, right? There were some offshoots, but through some of the people in FNOR was exposed to these thought processes of the brain, and that put me in touch with Traster, and that put me in touch with just this idea of like learning about the brain through all these, you know, David George and Stuart Fife and all these people that are applying it in different ways. And that, you know, they kept hearing about, and that takes us, I don't know, 4 or 5, probably 5 years ago now. And that took us to Nick keeps saying, there's this clinician, there's a chiro in Oak Park. He's a great guy. You got to meet him. You guys are going to get along. I mean, being like, all right, well, eventually, whatever. And Nick came in and he brought Mike had the yellow Camaro and dropped him off. This is this guy in the yellow Camaro and Camaro, right?
Yeah, Mustang, but
Mustang, yeah. Detroit car, yeah, muscle car. And so that was sort of, I don't know if that answers your question or not, but you know, I've always been interested in like filling in my gaps. And I feel like the more I've studied a lot of systems, I've sort of recognized through working with Mike actually, and just trying to have a mindful practice that I have and being wound up with anxiety, that I am a control freak. And one of the things that I can control is studying and creating projects. And I think that's where a lot of the book came from. And that's quite frankly why I think I've gotten to be, quite frankly, as good as I am as a physical therapist, you know, and different than a lot of other clinicians, is because of my desire to learn. And I've taken a lot of different types of courses and recognized and just tried to fill in my gaps. And I think I talk about that in the book. It doesn't matter what foundation you have. We all should anchor to one thing and get really good at it, and then recognize that there's going to be some holes within it and go fill in the gaps. And so that's where my dive deep into like the brain has come in, is like trying to fill in those gaps for me within three-dimensional movement.
Yeah, and I think that's the mark of a good practitioner, somebody who can identify their holes and then find ways to fill in those holes and just become more and more well-rounded. And yeah, I really respect that.
Well, that's like the amazing thing about this neuro stuff is like the more you learn about it, you're like, holy crap, there's so much I don't know, and there's so much to learn, like detail. And the amazing thing about it, when we look at neuroanatomy compared to like three-dimensional movement or applied functional science to a certain extent, there's a lot of the same principles. It's exactly the same. I remember watching somebody, Gary Gray, work with somebody, or these people that are really good at this integrated thought process that at first, when you first see it, you're like, what the hell just happened? I have no idea what just happened. I know it sort of made sense. I'm so confused right now. And then the more you learn about it, the more you're like, oh, that makes sense. And it becomes very logical. And I felt the same thing watching Mike and watching you and George and Dave work, is what the hell just happened? I know it made a little bit of sense. And the more I learned about it, the more I have. And one of the other things that they have in common, that like integrated or true movement and neuro, is that the idea of drivers, and the idea of putting an input into the system. And if you know what should happen for any input, you can see if it happens or not. It's the same thing. If I know that I should reach, when I'm looking at the camera here and I take my right hand and rotate it behind me, I know that there should be a left rotation of my cervical spine to some degree. And if it doesn't happen, I'm going, well, why didn't that happen? And I know that when I'm watching somebody's eyes move, they should be smooth. And when there's a bump, you say, well, why did that happen? And it takes you to the next question.
Mm-hmm.
So.
Exactly. I think, so this book is obviously about movement, and you take, a pretty all-encompassing approach to it. I think one of the most classic types of movement that I think of is just walking or gait, which is something that almost every practitioner probably looks at, right? So I'd be interested, I think this might be a fun thing, if maybe like you both take turns and go through kind of your thought process when you're watching someone's gait. And I don't know who wants to go first, but
Mike D, you're up. Go.
Adam, you can go first and go through your musculoskeletal things, and even though you see, I know we've talked about the neuro side of it, but
yeah.
Let's do a rock, paper, scissors for it. All right, I'll go. Okay. I just feel like I'm talking to someone. Watching, my understanding of gait is really founded in two books. One is Human Locomotion by Tom Michaud, who's a chiropractor, and I sort of feel is like the go-to book and resource for really understanding and applying information from gait. The other is the book Normal and Abnormal Function of the Foot by Merton Root, O'Brien, and Weed, which is like, 60 years old at this point. And it goes really into the foot, and not only like mechanics of gait, but mechanics of all the joints, and more importantly, the abnormalities that you're going to see. And so that's really where my understanding comes from in terms of gait. I think it was solidified probably through Dr. Studholm and Dr. David George and Stuart Fife, who talk about it a lot in EFNOR, and really brought it to the forefront of like, okay, well, how do I apply it more logical? Because when I first came in and started looking at gait, I was looking at it from an applied functional science perspective, which is very true, and to understand what should happen when your foot hits the ground, in front of you, and what happens when your foot's behind you is it's the trail leg. Those are all really important, and they look at it from they call it transformational zones. So the point in time when the body stops, the sequence into a movement and the sequence out of a movement. You could think anything has transformational zones, pitching, different positions, left foot hits the ground, right foot hits the ground. All these kind of things are transformational zones. So the Gray Institute talks about gait really from, at a simple level, two transformational zones. When your foot hits the ground, when your foot's behind you and toeing off. And understanding that when your foot hits the ground, there's a bottom-up drive into the system, meaning when your foot hits the ground, the bottom bones are going faster than the top bones. And so to understand that this concept of bones moving through space, but the joints, which are the space between bones, feeling motion, and that the bones can go through one motion, but the joint can feel exactly the opposite motion based on where it's coming from. So this understanding of gait and this idea of front foot and back foot and transformational zones, I learned for probably the first 10 years or so. Then I got more into understanding the gait. And the problem with that, and I love that thought process, I really do, and I'm anchored in it, but it's hard to reproduce. And it's hard to talk amongst peers and what I see, and that was always sort of a gap for me in terms of applying this information between practitioners or between colleagues. And then, so this idea of anchoring to human locomotion and what should happen, this idea of phases of gait or capacities of gait is the way I've heard it termed, and just understanding that at heel strike, your hip should be at a certain motion, your knee or your hip should be in a certain position, your knee, your ankle should be in certain positions. From heel strike into foot flat, there should be certain motions that occur. Are they occurring, yes or no? At mid stance, there should be certain motions, positions that are being reached in terms of at the hip and the knee and the foot. At toe off, same thing. So now, while I still apply this idea of applied functional science and understanding what bone's moving faster, the top or the bottom, right? The front foot and gait, it's the bottom bones typically move faster. When your front foot becomes your back foot, right, through the swing leg, and now what was your front foot is now your back foot, it's typically a top-down motion into that back leg and gait. So understanding that the top bones move faster instead of the bottom. So all that applied to watching somebody walk, you know, literally filming them go down and back and across the room or on a treadmill and getting them from the front and the side, and stopping at various points in the gait cycle and seeing are the joints in the positions we want them to be, and yes or no. And if not, then okay, well, why wouldn't it be? Maybe I need to look at this joint. Maybe we need to look, is there not enough stability? Is it not enough mobility somewhere else? It's causing too much motion. So then it becomes a matter of, you know, I look at all rehab, and I'm sure you can understand, it's sort of your choose your own adventure path. You know what I mean? Like, I don't know what I'm going to do with you until I put the input in, and then I'm going to see if are we going to go this way or that way. And so that's the way I sort of had started to look at gait more and more, is just anchoring to because there's a bunch of research on gait. We know, like, more or less what positions joints should be in and what motions joints should go through gait. And so then it becomes watching someone walk, filming it, looking at it again and seeing if it happens or not. It takes 3 minutes or less. Now, since I've been diving into the neuro stuff and really talking and watching Mike and Dave and you work, I now add this whole other layer of, okay, well, the arm, and I don't want to talk about it because I don't want to steal Mike's thunder here, but, you know, I've started to try to apply more of this higher level, again, rather than bottom up, top down approach. So Mike, what did I miss, man? Fill in, go.
No, that's fantastic. Yeah, that's what, like I said earlier, these kind of how our conversations go with Adam and I regularly, where it's, you know, how he thinks of things and how he's been trained and the things he's learned from so many people, you know, from that aspect. And when he talks like that, a lot of times I would have to like slow it down, you know what I mean? Go to half speed and see if I can even understand or, you know, listen to it again, understand it again. But so from my aspect, I mean, I look at some of those things on a much smaller level, but most of the people that I'm seeing are not, they don't have those biomechanical errors, or at least that's not what they're in for, right? Somebody's not coming in most of the time and saying, I have this knee pain or hip pain or back pain type thing generally, right? They're coming in for more complicated neuro things from the sense of concussions and even strokes or you know, any other neuro thing going on. So the stuff that I'm looking at is, as I have somebody walk down the hall and walk back towards me, I'm looking at what is their head position as they're walking, and does that change, right? So where do they tilt their head one way or another as they're walking? After they turn, do they suddenly develop a head tilt, or does it suddenly go away? Does their head become straight after they make a turn and come back towards me? The associated arm swing, right? So as they're walking, you should have this cross crawl mechanism where left leg is going forward, right arm is going forward. You should have this back and forth motion. And is that equal to both sides, right? Or do you see some people where they're walking down the hall and their right arm, let's say, is just plastered to the side, and you see the left one swinging away like it normally should, and one is just not moving at all, right? And that starts to give you some aspect or understanding of what's going on the opposite frontal lobe, or really the opposite cortex. What's happening? Why are they not getting this, what should be a reflexive motion going on? Why is it so rigid, right? Do they have a shoulder injury? Maybe, right? Did they have something that was mechanical there, or did they have a brain injury that is now causing a problem for that arm? So I'm looking at that. I'm looking at stride length, right? Is one step shorter than the other? Do they have some sort of shuffling gait type thing going on? So in like a Parkinson's or Parkinsonian type issue, is it early? Like you look at somebody who comes in and they say, well, I'm starting to, you know, even before like a tremor, you know, I'm just, my brain's not quite there. I'm a little foggy. I've got this constipation thing and shoulder pain and that, and I'm kind of anxious, right? And you may see these early signs of Parkinson's, you know, many, many years before they start to develop a hand tremor, because they're losing associated arm swing, or, that's just a simple one, or their gait starts to look off, right? They start taking more steps than they should in a certain time frame. So I look at those things. I look at, even when they're walking back towards me, I'm looking at how their eyes are level. Are their eyes completely level with the horizon and level with how they should be in the orbits, or after they make the turn, do their eyes suddenly go unlevel? And is that different than what I saw in the exam? So when my typical assessment of gait is towards the end of my exam, so I've already looked at a lot of different aspects of their system, and I have a decent idea, let's say, of kind of what's going on. So then I start comparing, okay, once they get up in not just a seated position or a laying position where they were before, but when they're standing and there's a different gravity, not really a different gravity load, but a different reflexive pattern due to walking and being upright on their 2 feet, do they start swaying one way or another? Is it changing their other neuro findings? Does it exacerbate their other neuro findings, right? Maybe somebody has a little bit of a head tilt, and then as soon as they stand up, they get this big head tilt thing going on, right? Does that, there's just little clues in the gait pattern that can give you so much. All this stuff I've learned and watched. I was super fortunate to watch Dr. Ted Carrick and his gait analysis. He's an unbelievable expert in gait. I would say he's probably, has the understanding where I say Adam has the experts in the movement part of the musculoskeletal movement part of it. And I know the neuro side of it. Dr. Carrick has both of those. He's a magician when it comes to that too. So, yeah, those are the main things I'm looking at. And does the gait pattern change then when I put somebody under a dual task event? So that's a lot of times I'll have them walk back and forth and see how things are going from just a baseline standpoint. And then I say, okay, now I want you to say every other month of the year out loud while you're walking, or count back by sevens from 100 or something like that. And you suddenly see people's gait pattern change completely, right? Where they may be walking pretty normal, all of a sudden you have them thinking at the same time as walking, and it all shuts down, right? Their arms go straight, they slow down, they hesitate, they start swaying. You'll see sometimes somebody will hesitate and then they just like kind of tip over to the side. You go, what? Well, if your vestibular system's intact and your frontal lobe's intact, all that, you shouldn't have the hesitation, and 2, you shouldn't be having this tipping or lateral pulsion, they call it, to one side or the other. And what does that look like, and what does that mean for their whole neuraxis, their whole system? Just trying to do a simple thing of saying every other month. And for some people, it's bad, and you know that they're already cognitively in a rough spot, and you say, hey, just say the months out loud, and you'll see, just trying to go through something that people should know from a very early age, that gums them up, right? They freeze, they hesitate, or they start walking normal and they get the months messed up, things like that. So there's so many different aspects of gait to look at, and so many clues that it can give you. It's pretty, it seems like a pretty simple part of the exam. Okay, walk down the hallway and walk back. But the amount of information that I gather from it, from just those few seconds, is remarkable.
Absolutely.
Listening to, I don't mean to interrupt, but like, I just want to make it, I found it really interesting because I just learned a couple things there. So I love these conversations where we hear, and it's fun because to hear you speak, we're applying a lot of the same information with different populations a lot of times. And the interesting thing, and what I've been really interested in, is like, where is the middle ground there? And and what I mean by that is, like, if somebody, you see clinical, I see like vestibular dysfunction, whatever we're going to call it. I mean, not that I see clinical from like a musculoskeletal perspective most times. I'll see some post-concussion and those type of things, stuff dizzy, but that's not where the most of what I'm seeing. And so what's interesting for me is to hear you talk about like these clinical applications. And then if you have it clinically, to some extent, you're also going to have the same thing subclinically. You're still going to have these dysfunctions. They just might be to a lesser extent, and they might be able to compensate through your nervous system a little bit better. But these are also things that I look at, like the dual tapping. Like those are also things that I look at. And I guess like one of the questions I have for you is like, why I go first with my gait. Joe, I'd be curious to know what you do. I do it first only because I try to do as much as I can before I touch them. And typically I do gait, and then I kind of move them around a little, some neurological stuff, some like squatting and those, and then I sit them on the table and do stuff, and then I lay them down. But I typically do the gait first. I'm curious to know why, Mike, you do it last. And do you think if you did it first based on the population you're with, and then you took them through your battery of exams, which is really pretty neurologically fatiguing for a lot of people, do you think that it would change?
Yeah, sure. That's a great question. It's kind of funny. I said in the standard exam, I do it at the end of it. But honestly, there's I know when we have kind of set exam times in our practice, and so I know when people are coming in, and where my office is set up is you have to walk past my door in order to get back to the diagnostic room, right? So a lot of times I'll actually watch somebody walking before I even see them, before I even meet them, before that. A lot of times, you know, as they come in, I can hear them at the front desk. And then as they walk past, I'll like peek my head out and kind of watch that. So, you know, I guess I am doing the gait analysis at the beginning, and it gives me a little idea. And then and now that you even bring it up, I didn't really think about it too much before. It's just kind of where I put it in my exam is towards the end. But I do like watching it at the beginning, and I have the habit of doing that. And there's times actually that I've seen the fatigability part of it, where I'll see somebody walking at the beginning and I'll have an idea of kind of how they move when they have no idea that anybody's even watching them. And then once they get fatigued, you know, let's say tired, depending on what they have going on, they do the diagnostic test, they do the exam, and then suddenly their gait is significantly worse. And it gives me an idea also of, okay, man, this person, they go through something that's fairly intense for you know, a couple hours, hour and a half or so, and then their gait completely changes. And that gives me an idea of how their brain is working on a normal day where they're being taxed at work or school or whatever. So I guess I do kind of look at it at both times. Yeah.
What about you, Joe?
Yeah, I mean, I think Dr. Mike brought up some really good points. After they go through a complete battery of tests, you can see their fatigability. But I think it's also interesting, you know, as you intervene or you find different therapies that you might try with the patient and see if you can make a change instantly. So, you know, a lot of things that we work neurologically kind of take effect very quickly. So it's very, very interesting, I think, for me to see changes happen kind of in real time. So I do see the importance of looking before and after, but also before and after therapies as well. Yeah, but I think you both answered that incredibly. And you had mentioned, Adam, one thing that I was actually planning to ask is, you're kind of alluding to the marriage of the two, kind of the neuromechanical and the biomechanical. So I was wondering kind of where that does find some overlap. So say, for example, Dr. Mike, you brought up the example of like a decreased stride length is something that you look at. I'm sure, you know, you do the same thing, Adam. So, you know, decreased stride length, they could come in, they say, my toe hurts, and that's why they come into your office. And you find out that there's a decreased stride length on the same side as the toe pain. Now that could come from a multitude of things. Could be biomechanical, could be neuromechanical, could be, you know, both at this point. How do you dissect that and really, I guess, identify which it is and how to approach that?
Great question. I think I try not to think is it one or the other, and because I think that if I'm affecting mechanically, I'm going to affect the neuro component as well, and sort of almost vice versa. I think in the world that I live in, there's probably a little bit of an expectation that if they're coming in for foot pain, I probably need to look at their foot and do something with their foot, even though it might be driven from above. So I look at, you know, on everyone, I look at, you know, dorsiflexion at that back phase, like, right, you know, before your heel comes up and as your heel's coming up in terms of knee. So I look at all that kind of thing. And then I also, one of the things that I learned, and I guess I always knew it, but I've been able to verbalize a lot more since all my learnings and with Mike, is this idea of summative assessment. And that you can't, you know, the way that I heard it, we have a podcast as well that was started, and one of our guests talked about you can't untie the relationships of the brain. I thought that was so brilliant, right? And so looking at it from a summative viewpoint, I'm always going to look at, okay, that decreased stride length on that side, well, maybe it's the calf complex, maybe it's the same side anterior hip complex, maybe it's both, maybe there's something there that they're not able to get it, maybe that decreased arm swing and they don't have shoulder pain, maybe there is something neurological. And so I also try to then look at the dual tasking and the rapid alternating movements and just, you all of it. And I think that I don't know that I separate them out and go, I'm going to go brain based. I'm going to go neuro. I'm going to go only mechanical. Because what is that really? Proprioceptive, right? So it's one system feeding the brain versus one of the other kind of two systems feeding the brain, and it's all the same. Can't untie those. And so I try to, for me, what's become interesting is taking these quote unquote brain based, maybe it's an eye exercise, a VOR, maybe it's a rapid alternating movement, maybe it's whatever it's going to be, and adding that on top of the exercise they're doing. So maybe I have them do some sort of calf lengthening or strengthening or whatever. And as I'm doing that, are they doing a VOR with it? Are they doing it after they do the stretch? Are they doing it, so sort of trying to layer it in. But one of the things I've really adopted is whenever possible, trying to layer as much to drive input to the brain, right? Left foot, okay, that's the right brain. And what else can I see that's the right brain? So just try to drive as much information as I can based on the threshold of the person I'm looking at and I'm working with. And that's going to change based on, that's what what we can all anchor to is putting those people at the thresholds, driving mechanical, driving neuro. Sometimes you're going to get more neuro through mechanical. Sometimes you can get more mechanical through neuro. And sometimes for me, it's do I layer it on top of the exercise, or do I have them do it in between exercises? Maybe I have them do a hold or a movement musculoskeletally and not focus their eyes on something, or not do a rapid alternating movement with it. And then afterwards, while they're resting, whew, that was tough. Maybe they're looking at something and doing a VOR, or they're doing the rapid alternating movement, or do I only have them do 3 sets of one and then 3 sets of the eye exercises? And I don't know, that depends on the person that I'm working with in the threshold. So does that answer your question, Joe?
It does, yeah.
All right, yeah, no, good.
What about you, Dr. Mike?
I would say it's a little, well, I don't know if it's hard for me to answer from just, let's say from that exact example, like the toe pain thing. Like I said, I don't have many people that are coming in and be like, hey, my toe really hurts, right? Let me think here. I guess, yeah, I do have a good example of that. I saw a lady not too long ago, a couple weeks ago, who, she was sent in by another doc, and she was sent in because she has a hand tremor. And she said, you got to go see these people. So she came in and went through the exam, went through all that. And I, of course, anticipating, what's her main goal? And it's trying to fix the tremor, because it was very visible. I could see that. And I said, what if you had the top of the list, what's one thing that I could fix for you? And she said, my left foot hurts. I was like, okay, well, we took a hard left turn there, right? But it turns out that her left foot was hurting, and her right outside, lateral hip was hurting. And she had gone to this other doc for a long time and worked on these, this other doc's very talented, working on the musculoskeletal aspects of things, trying to work on her foot, work on her hip and all that. And then once we put her on the posturography plate, and then just having her stand there and watching her, how she sways with her eyes closed, you could see that she had this right posterior sway pattern that was pretty significant. I'm not just a little sway, but she'd go and basically lose her limitus or exceed her limitus stability and almost fall back into her right. And so I approached it, different than like Adam said of, they expect you to look at their foot. And I think this lady maybe did too. And I actually explained it to her. I said, hey, a lot of other people have looked at your foot and looked at your hip. I'm going to take this from a different approach. And it may be a while before I even look at those things, because everyone else has. And I know the person who did it before, and I trust that they were probably doing the right thing. So then we fixed this lady's balance stuff. Turns out that she had a concussion in the past, fell off a bike, hit her head. And it changed her awareness where her body was in space and her vestibular system. So she had this poor sway pattern that's going on all of the time. And it resulted, she didn't know, wasn't dizzy, never fell, never anything like that, but didn't even know that she had this abnormal vestibular thing going on that was then causing hip and foot pain. And we fixed that, which was pretty great. She responded very well to that. And then all of a sudden she's like, yeah, I can walk for a long time. My foot doesn't hurt anymore. I haven't had, I almost had to remind her about how's your hip feel? And she's like, oh yeah, I had hip pain. She completely forgot about it because it just wasn't bothering anymore, because then her movement pattern was normalized, right? It wasn't that there was a problem with the actual foot or a problem with the actual hip. It was that there was too much abnormal movement patterns or wear and tear and inflammation, all the stuff that leads to that because of stressors placed on it, because she couldn't hold herself perfectly upright. And so that's kind of I don't know if that answers it perfectly, but it's kind of my approach
I
or
like,
how I think of the musculoskeletal side of things.
Mm-hmm.
I love it. I mean, and that's sort of where my head kind of went as well as I stopped talking, and I was going to bring that up also, but like, and I'm going to just kind of simplify what you said because you said it really smart, and it sounds, but like the other piece is maybe they have like less toe pain because they feel like they're falling back to the right. I think that's sort of what you're saying to a certain extent, or where they feel like where they think neutral is, it ain't, is the way that I kind of look at it, right? Like if they feel like the neutral is back to the right or they're falling back to the right, well, they're going to come forward to the left, and all of a sudden there's more pressure in the big toe. And so those pieces. So that's where this idea, for me, summative assessments come in, right? Like, and I use a balance type plate as well, a beat track. The balance tracking systems is the one that I use. And it's a little less fancy than what you all have there, but it gives me enough information to kind of get, and that's something that I look at on everybody. Everybody that comes in, I put them on that. And I think that's true objective information. And I think that, so I try to, at this point, get as much objective information as I can on people. So I can, you know, do what I need to do and still come back to that test and look at it. So I'm glad you brought that up, Mike. So yeah, you know, they feel like they're falling one way, let's correct it. And that brings in, you know, what I think, and as I've learned, especially from talking to Mike so much, is, you know, this idea of like the person that has neck pain. Here's another example, right? The person that has neck pain that comes in and they, oh, my neck is so tight. And they're always like this. And well, maybe they feel dominant in one canal versus the other. So, you know, these people, they've been to PT, they've been to chiro, they've been to massage, and it feels better and it comes back and nothing changes. Well, maybe they're getting uncompensated. Maybe their neck is being positioned there and it's tight on the right because maybe they're dominant into the right horizontal or their right vestibular system versus their left vestibular system, and they're getting put in that position. So understanding that, and then more importantly, having the tools for me to check it, and even the simple exercises to be able to do something about it, is interesting. For me, one of the challenges for me, because I like to just know as much as I can, is like, how deep do I personally want to go into this? Because what's it really going to do to affect like my personal practice? And the way that I've come across it is like, when people come to me and I see these sort of subclinical integration type dysfunction. In fact, I'm writing a case study on it today for Instagram, and there's a patient that came into me last week. And we had seen him like 2 years ago. He came to us after surgery, but he had bilateral anterior compartment syndrome releases of his anterior compartments. And so then he came back, we rehabbed him for that. And then he came back in last week and he had bilateral knee pain. And I put him on my balance pad, and like so much of his weight is backwards. He can go backwards way more than forward. Now I was thinking, okay, well, he feels like maybe he's falling forward in one direction, so he's going to lean backwards. Oh yeah, I noticed in the past couple of months I'm striking a lot more on my heels and all those type of pieces. So rather than what I would have done back in the day, which is like rub on his muscles and his knees and try to like give him some, strengthening of whatever, and now we've just been working on like driving his posterior chain, right, through eye exercises. You could see it in his eyes, and just working on him to feel like he can get forward a little bit. And it's made a huge difference. His pain went away. So that's, for me, sort of where that middle component is of how to apply it within sort of this brain-based world. And for me, when people come in, I really truly feel, after being a PT at 15 years, if you come in with musculoskeletal pain, I've seen it all at this point, more or less. And if you're not getting better in 4 or 5 sessions for me, I'm either missing something musculoskeletally, or more is the likelihood. I feel like it's not musculoskeletal at this point. I feel like it's probably being driven centrally. And so for me, the cutoff is, well, how deep do I want to go? When you need the fancy $25,000 goggles, that's when I refer out to you. And then I refer to your practices because we're close together. I have the $1,500 pair of goggles that I can look at. But when we need to get a little bit more specific in objectifying information, from this central perspective, I feel like that for me has become the dividing line of when I will pass that along. And for me, I can see that within 4. If you're not getting better in 4 sessions, I'm missing something. It's either musculoskeletal. It's probably not, because you've been other places if you're coming to see me at this point. And so that's for me become the dividing line there, and sort of that marriage of the two, I think.
Yeah, I think you guys did a great job of answering that question. And I think to that point, the example of the kind of the vestibular imbalance that may be causing maybe a gait abnormality in some way or the other, by fixing the maybe by working on the muscles, you may not fix the vestibular problem, you may not resolve the issue, but by fixing the vestibular issue, you can regain normal gait. However, in some cases, you may need to then kind of address the tissue damage that may have from maybe years of chronic imbalances in gait, and then you want to focus on the the biomechanical aspect of things that are kind of residual from that. Do you see that often in your practices?
I can say that
Mike.
for that specific patient that I used the example on, that she had the hip pain and the foot pain, the hip pain was completely gone with the neuro rehab stuff that we did, but she still had some leftover foot pain. And so then it was kind of like going back into the, I am trained in, of course, other musculoskeletal things. You can still do those things, even though I do a lot of the neuro stuff. And I did some simple things were some instrument-assisted myofascial release with an instrument or a tool, and use some Prolo gel, which is a type of gel, anti-inflammatory gel, the sensory nerves. Did a couple simple things on her foot from the to try to reduce inflammation that was still there, and try to help just, again, it's inputting proprioception into the actual end organ, into the foot. But then, trying to work through those muscles and maybe whatever adhesions or whatever it was that was down there. And then her foot felt better afterwards. But I didn't work on her foot probably for quite a few sessions because I was working so heavy on the other stuff. But then, of course, following it up with okay, let's take care of the biomechanical things that are going on with your foot because of years of abnormal movement through that actual tissue. Yeah, for sure.
Go ahead.
Go ahead.
Okay, so I just wanted to get back into the book a little bit and kind of the specifications of the book. What can people, I was going to ask, what can people expect from the book? I feel like a lot of this is what they can probably expect, just in much, much more detail, and something they can continue to refer back to. But what are some of the key things that you two tried to hit on in this book?
Mike, you go.
Okay. So that's a great question. Of course, it's like I said, the conversation that we're having here is much like the conversation Adam and I have all the time. I feel like it is that in the book too, but it is in a much deeper level and breaking things down from a mechanical standpoint. Adam goes through so much. So basically how it worked, Adam wrote a lot of the book, and then when he had asked me to come on to kind of neuro edit it, like he says, I was reading through so I was able to read through the book a few times and then to put my 2 cents in here and there. But like looking at it's so dense with movement information that Adam has in there. And then I throw in a couple of the neuro things. And so like when he's talking about a certain movement pattern, I'll say, and this comes from here, or this comes from this specific group of neurons or neuronal pool, or a certain movement pattern type thing that's built in the brain in this area. So that's kind of how I jump into it a little bit, just piggybacking off of all of the things that Adam already really had built into the book. And I think there's other cool things that are in there. There's a couple of case studies and things like that, which are super interesting, of course, when you can take the information that is textbook and then apply it to a patient, because sometimes that's a hard thing to do for a lot of cases. And one of the very interesting things was Adam was humble enough to put his own case study in there, and you don't see that a lot from a lot of people. They there's always this thing of people don't want to show what might be considered a weakness, or even if other people don't consider a weakness, they might think it's their own weakness or something. And Adam had come out right away and said, hey, I worked with you, because when Adam had come in and seen me, and he said, I saw some great results, and I was, I learned so much and all that. Like, why don't we just put my case study in there? And he opens up about, stuff that he's dealt with in his life, and the process, how that affected him, but then also the process of getting it fixed, and my thought process on going through that. And I think that's a really cool part to the book, because it, a lot of times you look at a book and you see the author's about section, and it's like on the cover of the book, or the back inside cover of the book, and you get like this much information about the author. In this book, it's kind of cool. You get a super deep dive into what is the neurology of Adam Wolf, which is, I don't know, it's a cool different a cool different aspect, different than you'd see in other books, right? So I really like that part of it.
Thank you. Yeah, I think one of the things that I've recognized as my strength is my ability to sort of synthesize information. So I've taken those Colby indexes and all those kind of personality tests. I'm good at synthesizing information and bringing people together, being, hey, you need to know this person. And I see that play out in my life, and I've really tried to take advantage of that. And I think what the book is like, for me, what it became is how do we reconcile, it became reconciling pieces that at first glance shouldn't go together, but actually really go together quite nicely when we can look at them. And so I think that that's what it was. For me, it became like, it's written in the way that I study, and I learned to study kind of for a long while. I literally would like have I called it the Journal of Truth for a long while. And it was just like, for me, you know, anchoring in applied functional science, I had a journal and I had a physical section, a behavioral section, and a biological section. So anything that I would read and it would apply to biological, I'd take it and write it down in the biological section. I'd write it down in the physical section. And so that's how I came to learn. And so when I learn around a subject, I try to get 4 or 5 different top resources on it and summarize and synthesize the notes and see like what can I anchor to and what makes sense. And so that's sort of really how the book came about with the movement. And then I got into motor control and muscle testing, and PTs tend to poo-poo muscle testing, but I really think that as long as we're anchoring to objective information that's really objective, muscle testing can be a really good guide to getting to places and verifying if we're on the right track or not. And so it talks about that in motor control. It got into pain. Actually, the book started, this is my second book. The first book, I left out the pain chapter because I was really intimidated about it. And I thought there's a lot of, how do I say it, people with loud voices in the pain science community. And I didn't want to go there. I wasn't in a space to like have to debate it and put myself out there. So I left it out. But I started writing along that chapter. So there goes into pain. And then as Mike said, there's 5 case studies, 2 that I wrote on people that I wrote on applying a brain base. And then 2 that Mike wrote of applying the musculoskeletal brain base, 2 that Mike wrote from the clinical perspective. And then the 5th one is on me. So I guess Mike technically wrote 3 case studies. So that's how the book sort of came together. And it's really just become like my philosophy. I love teaching. I have a passion for it. I love treating. I have a passion for it, is to give credit to everyone that I ever learned everything from. I haven't made up any of this. I'm just really good at synthesizing information and bringing together these pieces. And so my approach to teaching, whenever I teach a live course, is sort of, I want to impart upon you information that you can use immediately, but I also want you to leave with more questions than you came answers, so you can go learn from the people that I learned from, and I'm going to give you the resources on where to learn it from. And so that's what this book really is. At the end of every chapter, there's an additional readings list. We reference just all sorts of different practitioners and people that work with movement, and that's the philosophy of the book. It's really, I think about it as a stepping stone when you want to learn more about 3-dimensional integrated movement, whatever we're going to call it. Go learn from these people and these different groups. When we want to learn about neurology, go to these groups. When we want to learn about gait, go to this group. When we want to learn, so all these kind of pieces there, I sort of tried to put it together with the idea of it not being the Bible of anything, but sort of the end all on anything, but more of like the beginning point to point you in the direction of where to go get more resources. That was really the spirit of the book.
Yeah, for sure. And I that's you kind of reminded me there too, Adam, that I was using language earlier saying, my 2 cents, but it's not really my 2 cents. I didn't come up with any of this stuff. And none of the things that I talk about are from just my own brain. It's all from people I've learned from in the past, and a synthesis of information over a long period of time, other mentors and research and textbooks and the ever-changing world that is neurology and clinical neuroscience. But yeah, to clarify from that exact same vein too, it's not really nothing in there is my stuff. It's just a conglomerate of things that I've learned in the past in the exact same thought process that you were just saying, to try to get you have a new clinician or an older clinician, somebody's working, but they want to get into a different sphere or a different world that they're in. What my thought in writing my parts was like, how can we get their wheels turning a little bit, right? How can just little different thought processes that maybe are a little different than what you would typically see or what they may have typically seen.
Yeah.
Mark Twain said it's the spin of the kaleidoscope. Nothing is new. And I think it is like how you say it. And I think that you're taking other people's information, Mike, and you're applying it in a way that makes sense to people that you're coming in contact with. So nobody made anything up. But again, one of the things I'm interested in, one of the reasons I love to have these conversations with you is because I love to hear what you think about it. And what's really fun for me, because I get tough clients and tough patients, and I drill you, like I record eyes all the time and I send it to Mike. I'm like, what do you think about this? And I get permission. But I'm also fortunate to have a good relationship with Dr. David Traster, who obviously you all work with. So what's fun for me is to text the same question to both of them and see what their answers are, or send the same video to both of them. And then I get these responses back. And it's great because they're always really, really similar, but of course it's their own twist on it. And so I feel like really super lucky because my best education on this stuff has come from, hanging out with my friends, quite honestly, and being able to like geek out and ask questions. That's what's fun for me.
Yeah. And who would you say this book is mostly geared towards? Who is going to get the most out of this book?
I wrote the book with the 3 to 5 year clinician in mind. I think it's appropriate for anybody that wants a deep dive into movement and understanding how to reconcile some of this. But the book was written for that 3 to 5 year clinician, that clinician that's worked with enough people to recognize how much they're missing, and the clinician that has the desire to go out and learn more. And again, where can I learn more about? And then use this as a resource to go learn from all those others. Now, I think it's applicable for the 25-year clinician when appropriate, and also the personal trainer or the movement professional that is new. I just think that it's written with that sort of in mind. It does get relatively deep into some subjects. Mm-hmm. Mike, what do you think?
Yeah, I think so. I mean, for sure it's a clinician book as compared to a layperson book, right? It's meant for the clinician. And yeah, it's really I think that's probably a good, the first few years that somebody's in where they're wanting to get out of the mindset after school, because you have a certain thought process after school, and then you start to see things, you get experience, you start to just learn more in practice. And then I know that's the path I've been on, and I'm assuming you too, Adam, that's when you start, okay, what is this? Or maybe I thought I knew everything. That's like you said earlier, the more you learn, the more you realize you have no idea what's going on, right? And so, yeah, I think somebody who's finding, 3 or 5 years into practice, they're going, okay, there has to be something else here. I've seen enough of these ankle injuries, right? And I keep hitting these roadblocks. What is it that's going on that I keep hitting that roadblock? What is there? There has to be something different. So I think a little bit of expertise in practice is helpful. But yeah, I think somebody brand new could jump right into it. And then probably somebody who's been working in the field, we'll say the movement field for a long time, may look at this and go, that's a cool way of looking at it, or that's something different, or I didn't really, or I'd thought something along those lines before and it confirms this, whatever it might be. Yeah.
Mm-hmm. Also is written, and I'm sure you understand, to a certain extent, not everybody needs Adam, and people come in want to see. I have a really great team that I work with, and not everybody needs Adam. Some people want to be I got to see Adam. No, you don't. You just need a really solid thought process that's consistent. And so the book was also written like that. How can I, for lack of a better term, recreate my thought processes that makes me an effective clinician? And I think that was also the effort of the book.
Yeah. Now we are just about at our hard end limit.
Gotta go treat some more patients, man.
Exactly.
I think all of us do, don't we?
Right. Yeah. So let's just take this knowledge and go apply it right now.
Exactly.
But so final thoughts. How can anyone reach out to you two, and how can people, more importantly, find the book?
Mike, go ahead.
Yeah, no, go ahead, Adam. It's how can they best find the book?
The book is on Amazon. You can find it on Amazon. If you put in Adam Wolf or Foundations of Movement, it should come up. I also sell it on my website. It's movementguild.com, or Adam Wolf PT is probably the easiest. It'll take you to that same website. My Instagram handle is Adam Wolf, WOLF PT. Pretty much that's probably the best way to get me through there. If you find me on YouTube at Adam Wolf PT, I got a bunch of stuff out there, but the book is available on Amazon.
Yeah, for sure. And I'm with the Neurologic Wellness Institute, of course, with this podcast and stuff. So all my stuff is through there. I think we have the Neuro Wellness Institute to Instagram and all of that too. And then our website also, the Neurologic Wellness Institute.
Those definitely in the show notes.
I want to thank you both for doing this, Mike. It's been great to write the book with you. We got to do it again. And Joe, appreciate you having us on here. Been looking forward to this for a while, man.
Yeah, thank you both for being on the show today. I think this was phenomenal, and I think this was probably our longest podcast. So congratulations, you guys.
We're both
set the
long-winded
record.
for sure.
I think Dr. Mike's got the most screen time out of anyone so far now.
As Dr. Mike should. Thanks, gentlemen.
No, it's always, I always appreciate it. Thank you, Joe and Adam. It's always a pleasure. So, thank you.
Of course. Well, this has been your host from the Neuro Wellness Podcast. Be well.